Now we'll invite the next speaker, Dr. Yashdeep Gupta, for another interesting case. The case is 32 years old lady with type 2 diabetes for 3 years at 7-week gestation, having HbA1c more than 8.3%.
Hello, it was a nice talk, Dr. Bindu. But I think for all of us, it's important to understand that a girl who has hirsutism and sort of we know that she has PCOS and she comes with amenorrhea, first and most important is rule out pregnancy. Even if she's unmarried, we must rule out pregnancy and then go ahead with all the investigations and management. And we should be able to diagnose what is hyperinsulinemia, the levels, and then so that we are able to decide when to start our metformin or insulin sensitizers. Thank you so much, Dr. Bindu.
Good afternoon, everyone. Sorry to interrupt Dr. Yashdeep Gupta, but we have one more addition to our panel of chairpersons. Her name was missed earlier, and for that we are very sorry. I'd like to invite Dr. Anita Sharma to come up and join us on our panel. Welcome, ma'am.
So thank you, chairpersons, and my sincere thanks to the SPEEDCON organizing committee for this invitation. So this is a case 32-year-old lady with type 2 diabetes for 3 years at 7 weeks of gestation, having A1C of 8.3%. So basically I will discuss this case under 10 discrete steps for management. The step 1 is basically when you encounter such a patient, you see that this patient badly missed a preconception care. When you take a further evaluation, you found that she has a BMI of 28.6. She also has an uncontrolled blood pressure of 146 and 84, and she had been taking Telma 40 mg OD for her blood pressure control. And for for diabetes, she is on vildagliptin and metformin. So basically, when you talk about this case, preconception care, there are 5 basic steps that got missed in this case. One is a safe drugs for glycemia. Ideally, this patient should have been insulin plus metformin, which is not in this case. Second is a goal for glycemia. Ideally, this patient should have A1C before less than 6% before conception, but the current case is 8.3%. In the worst case scenario, even the A1C should be less than 7% before conception. When you talk about the drugs for the comorbid condition, the patient is on Telma, which is a teratogenic drug which should have been stopped before conception, and she is taking that drug. When you talk about comorbidities, apart from hypertension and diabetes, weight is another comorbidity because all we know that pre-pregnancy BMI, gestational weight gain and glycemia have additive and independent effects on the poor maternal and neonatal outcomes. So basically she is an overweight lady and should have lost some weight before planning a conception. And the fifth and most vital part is a complication screening. Type 2 diabetes, you don't know what is the duration preceding that diagnosis phase. So she should be screened and should have undergone screening for at least 2 microvascular complications, that is retinopathy, nephropathy, and 1 macrovascular complication in selected cases, that is a cardiovascular assessment. So these are the 5 basic steps which has to be undertaken in each and every woman before conception. And when you talk about the drug, she is not on Folvite at this moment. So there is something that has to be taken out and certain drugs which has to be put in before this patient should have undergone conception. So basically she had not undergone these things, and the first step and foremost will be to get a routine investigation and chart out a management plan for this patient so that all these 5 steps should be undertaken at the earliest. Going to the second step, after the baseline assessment, then comes the action point. Action point, when you talk about the action point, these are 3 discrete elements which has to be taken care at the first antenatal visit. Glycemia, you need to refer to a dietitian for a diet advice. You need to prescribe the physical activity, maybe a 20 to 30 minutes of walk at least to start with. You need to put this patient on insulin MSI definitely, because she is on 2 drugs and she will require something around 20 to 40 units of insulin. So she need to be put on multiple subcutaneous insulin infusion. Metformin is plus minus, you can continue, but there are some riders for the metformin which we will discuss in a subsequent slide. Second foremost part is a hypertension, because it again has an additive effects on the poor maternal and neonatal outcome. She should be switched to the safer drugs, methyl dopa, labetalol, nifedipine, depends upon the choice of a obstetrician, but this is a one we have to select from this group. The second thing, maybe not from an endocrine perspective, we will be taking this decision, but obviously will be need an early referral to a gynecologist for starting ecosprin, because it has been shown to decrease the incidence of preeclampsia. So the third foremost part is to arrange a quick referrals. If it is from endocrine side, the patient is presenting to the endocrinologist or the diabetologist, obviously obstetrician should be involved at the earliest, and a cross referrals for the retinopathy assessment has to be made. So these are the three basic action points that has to be taken for the first antenatal visit for this particular patient. Going to the third part, for the management point from an endocrine point of view, this patient needs a diet advice. When you talk about a diet advice, there are a number of parameters that has to be taken into account. The diet is basically primarily not only aimed at achieving euglycemia, that is obviously a foremost goal, means the patient should not have hyperglycemic excursions, or patient should not have hypoglycemia on a prescribed diet. The diet should be nutritious. When we talk about the nutrition, it should contain the macronutrients and micronutrients. It should be from that angle. It should be to the satisfaction of the patient. It should not be just a prescriptive advice. You should need to take out what patient eats. You just get an idea what sort of food she prefers, and then depending upon that choice, cultural habits and her appetite or the current level of intake, we have to adjust the diet. So appetite and the preference, that goes into the satisfaction domain for this particular patient. Then one should not forget about the gestational weight gain. She is an overweight lady, so the total gestational weight gain should be aimed around 7 to 11.5 kg. It's generally preferred that if his patient is a diabetic, a lower range should be preferred. For example, 7 to 9 kg will be all right for this particular lady. Then you have to monitor diet for a fetal growth. So whenever you prescribe a diet, especially when the second and third trimester you have a repetitive fetal growth measurements, the diet may have to be adjusted depending upon how the fetus behave in terms of growth. So this is a dynamic assessment and dynamic changing or prescription of a diet that should take place through whole of a pregnancy. There are some vital points which has to be kept into mind. This diet should not be less than 600 kilocalories, not less than 45% carb, not less than 175 gram of total carb, and should not be high glycemic index. So diet prescription should take into account this sort, because otherwise the deficient carb diet will lead to the ketosis, which is again harmful for a developing baby. The diet should be split into 3 meals and 3 to 4 snacks, and what is important is the timings. So the diet should be fixed in timings and consistency. So whatever she takes, it should be a fixed amount on a daily basis and at nearly the same time. That is very important when we put patient on MSI thing. And again, just to repeat, it should be a regular review, especially when patient lands in the second or the third trimester or is in the postpartum. So this is a diet concept. Basically, in normoglycemia, you can still tackle with the 3 major meals, but to prevent the hyperglycemic excursions in the GDM, you have to split the carbs. So it's a 3 plus 3 basic meals, breakfast, lunch and dinner, and you have to put 3 snacks at least, mid-morning snacks, mid-evening snacks and the bedtime snacks. And it has to be spaced in between the 2 meals so that there is no postprandial excursions, or it does not affect the pre-meal value when it is taken at the right time. Usually the breakfast lunch in Indian setting is very close, so a very small snack is needed in the mid-morning. Lunch and dinner gap is too much high, so that you may need to split evening snack into 2 snacks. What we do is prescribe snacks around 4 o'clock and 5:30, and usually ask lady not to take beyond 5:30 because usually it then impacts the pre-dinner value. So these are the diet concept which has to be taken into account. So just to reinforce, apart from glycemia, gestational weight gain is very important. This is a snapshot from our pregnancy file. So we do monitor weight in each and every visit, and this is a strong practical point, because just monitoring a weight, we get a lot of sense from a patient what she is doing in terms of diet. If there is no advancement in weight, so we come to know that patient is trying to restrict the diet to just prevent insulin initiation or glycemia control, or there is some thing not going well when we prescribe the metformin. So the weight monitoring has to be done on each and every visit, and what need to be taken into account that we usually take 4 weekly weight. So 280 gram is a target weight for this overweight lady. So if she's not getting 1 to 1.5 kg per month, there is something wrong with the diet part, and the reassessment is required. Coming to the physical activity, usually 20 to 50 minutes of physical activity is advised to these patients. 20 minutes it depends upon how much the physical activity lady is, and then you can custom made the physical activity according to the glucose patterns. For example, if you see the post meal excursions, it is better to place the 10 minutes walk 30 minutes after each meal, so that the postprandial excursions can be taken care of. If you see that there is a pre-meal excursions, then it is better to put a 20 minutes walk in the after the evening snacks. So it's a 20 to 50 minutes depending upon the patient comfort and the time that she can devote, but obviously it has to be tailor-made so that best can be achieved from the physical activity. And the second thing is that it is only a short lasting act of a physical activity. So if it is tailor-made, it gives the best benefit from to a particular patient. Before prescribing physical activity, especially for a diabetologist, one should make sure that the obstetrician has any contraindication from an obstetrician point of view before prescribing the physical activity. The step 5 is an insulin, which is a practical consideration for this when patient is with us. One is education. We send to the diabetes educator to teach patient the particular insulin technique, hypoglycemia care, how to maintain a log for blood glucose monitoring and dose adjustment. When it comes to the insulin choice, usually there are two: insulin conventional and the analogs. We usually prefer conventional insulin for the type 2 diabetes and the gestational diabetes, because these patients are at low risk for hypoglycemia. But if you have a type 1 diabetes, we strongly prefer an analogs for a patient who is at high risk of hypoglycemia. So this is how we base our choice depending upon the phenotype of a patient. Insulin regimen, again, you have to assess mentally how comfortable the patient is and what is the glucose log. So we tailor-made or start with a basal plus or basal bolus depending upon the level of glucose and the comfort level, and quickly go to the basal bolus regimen for a particular patient. Again, we don't use a weight-based recommendation, because the level of glucose dictates the amount of insulin required. It's a sheer weight-based management sometimes can lead into hypoglycemia. So depending upon the glucose level, you can titrate or the medication's insulin dose. Step 6, metformin. Obviously, when you see a type 2 diabetes patient, especially with a overweight or obesity component, metformin has been seen to reduce the requirement of insulin by 20 to 35%. So from that angle or pragmatic point of view, you can prescribe metformin, but before you prescribe metformin, one should be sure that patient doesn't have any contraindications. One thing that has to be kept into mind, especially when the patient is in initial 16 weeks, if she has a nausea, vomiting, then metformin is not a good drug at this stage. If she has a complicated pregnancy, especially when prone to preterm birth, or patient is undergoing an IUGR baby, metformin is not a drug to be prescribed for such a patient. The patient when can go into the preeclampsia, chronic hypertension, again the metformin is not a drug of choice for this patient. Not drug of choice, not even add-on. When the patient is gaining suboptimal gestational weight gain, we usually don't prefer metformin for such patient. And when the patient is obviously having fetal growth retardation, we take off the metformin from such patients. The additional consideration we use, given that there is a borderline evidence for the metformin and only till 9 to 10 years, we usually try to restrict our patients on 1000 milligram per day. Split doses into 500 each and usually preferred after meals. And then regularly review and use that diet chart for what I showed, that gestational weight gain, to titrate metformin and the complications, take into account the complication that develop during the pregnancy. If this patient is with me at the first antenatal visit, usually I will prefer to see this patient within 2 or 5 days, maybe in the next or the OPD. So if I'm calling patient, I need at least 3 values in each row. So we ask patient to do a 6-point monitoring or the first antenatal visit, so that we can take our decisions for titration. If I'm seeing this patient after a week or 1 week, this is what we ask patient, so that we don't burden the patient and we get a scientific information, whatever is required for this patient. We usually prefer a pair readings, and I will show that what pair readings, how it helps, because when you prescribe the prandial insulin, you want to see the postprandial excursions. For a postprandial excursion, isolated after meal readings will not help. So this is a log which we prefer when we see patient after 1 week, pair reading for 6 days, and a full 6 readings on the 7th day. And these are the targets: less than 95, less than 120 for the pre and the post meals respectively. The A1C should be less than 6% during whole pregnancy. Step 8 is insulin titration. The 3 basic principles for titration is, when you titrate about the prandial insulin, you see a gap, where if your blood glucose is going more than 120, and the difference between the pre and the post meal is more than 25, obviously you can up titrate. If you see the blood glucose at the postprandial dipping as compared to the preprandial, you have to decrease the insulin. So this is a basic concept for titrating the prandial insulin. If it is a pre-meal insulin which is rising, then you have to fix the snacks, you have to fix the fasting plasma glucose if it is contributing, or it could be the previous segment which is contributing to the pre-meal glucose regimen. So the gap, when you titrate about the fasting insulin, bedtime insulin should give a dip of more than 25. If it is less than 25 dip and the fasting is elevated, you have to titrate the basal insulin. So this is a 3 basic steps for titration of the insulin. Then the technology, most of the things will rapidly shift to the technology part, so it's important to discuss this also. So apart from the self-monitoring blood glucose, pre-meals, post-meals, and the A1C, it's important to have an idea what this CGMS system gives an idea. So the recommendations from the CGMS point of view in the diabetes complicating pregnancy is time in range. How much patient spends time in 63 to 140 range. So for a type 2 diabetes pregnancy, it should be more than 90%. Then the average glucose, what you see in the left-hand side panel, it should be around 115 milligram per deciliter. So these are the 2 additional parameters. If you see such sort of graphs, you can judge where the patient actually lands up. So when you have a patient where the glycemic variability is high, log is unpredictable, the technology comes into place and you can make up additional information from a technology point of view. The upper graph shows the variability for a patient of a type 2 diabetes. Lower graph is from a GDM where you can see 96% time in range as compared to a graph for a pre-existing diabetes which show only 41% in target range. So these are the 2 CGMS systems will be quite handy in subsequent management of the patients. So this is a freestyle libre. We make sense of a freestyle libre, the trends. It's not good for its value, but it's very good for its trends. When we see the trends, the rapidity of rise after meals, this means this patient is a candidate for the analogs because we want some insulin which acts quickly and matched to the pre-postprandial excursions. For this particular patient is a type 1 diabetes. The patient was on 36 units of insulin. When we saw that patient's trends is very fast, postprandial excursion switched to analogs, the insulin requirement came down to by 50%. And the time in range increased by 24% within a week without any hypoglycemia. So technology could be quite handy when you monitor the blood patients of a diabetes in pregnancy. The step 9 is this patient when delivers in the labor room. So these are the 3 or 4 points that has to be kept into mind. The targets is basically 70 to 110, not more than 126, and not at all more than 140 on patients who is in the labor room. The monitoring frequency could be 30 minutes to 2 hours, 30 minutes when the patient is undergoing C-section, 2 hours when the patient is in the first stage of labor, and gradually increase to 1 hour when the patient goes into the second stage of labor or is a prolonged labor or there is a pushing efforts or additional complications. The second thing which has to be kept into mind, the choice of fluid. If the patient is having active labor, prolonged labor, pushing efforts, and is NPO, the choice of fluid should be DNS rather than the normal saline for such patient. Better to keep insulin infusion and the DNS separately so that you can titrate each one separately. The fourth thing that has to be kept into mind that the insulin sensitivity suddenly increases postpartum and the doses reduces to 60% of the what is going on during the pregnancy. So the rapid titration will take place subsequently in the next 2 weeks and you should be aware for that. The goals are somewhat relaxed, 110, less than 110 preprandially, less than 160 postprandial thing. The last basic step is a postpartum care. This is where most of the things goes wrong because the patient loses the contact with the obstetrician and is not in touch with the diabetologist. So it should be, it's not important, it's essential that even the patient who is a GDM, this is a particular case is diabetes, even in the GDM who is diet control, it's better to send to the diabetologist so that the postpartum continuity of care could be maintained because it may be the case of a GDM which has complicated to the type 2 diabetes during second pregnancy. So this is a to J approach which we follow, which we do follow in our practice. A is assessment for all sort of complication, means comorbidities and complication. B is a breastfeeding, contraception. D is for diet. E is for exercise. What's important and why I want to highlight is a family involvement. We usually do involve husbands at 32 to 34 weeks. The reason is that after 34 weeks, we need patients to follow up after every 1 week and not all ladies can make up every 1 week to the clinics. then we want to see this patient rapidly for 3 to 4 visits in the initial 6 postpartum, and we don't expect ladies to linger in the hospital with the small child for frequent visits. So there is where the husbands comes handy to us, and they usually bring us the log, we titrate, and the continuity of care is maintained. I will show a slide with the goals. Then again, we have a system, should have a system which is a friendly, like for example, we run a special clinic for gestational diabetes where there is no appointment, patient can just walk in and quickly get out of the hospitals. The individualized attention and joyful living, the psychosocial assessment is very important for this sort of patients. So this is a postpartum plan for such patient. You need to see patient 3 to 7 days, 2 to 3 weeks, 6 to 8 weeks, because these are the turning points where the insulin doses will change rapidly. So this is a log where this is a chart of a postpartum women where we document the goals, the values in the postpartum visits, and then this is a patient who is preparing for the next pregnancy. So you see the TSS 7.74, this gives an opportunity for preconception optimization of thyroid status, and we stress the patient that BMI is 25.2, lose weight for 5 to 6 kg for planning, before planning the next pregnancy. Because again, the step 1, which to summarize, the step 1 where the patient landed up in the pregnancy with the uncontrolled comorbidities without any particular evaluation, this patient can go back to the next pregnancy with the same sort of stuff if we don't have an inter-pregnancy care model. So the things has to be taken care of preconception, and the continuity of care has to be maintained in the postpartum for this patient. Thank you for your kind attention.
Thank you. How much time she took from 8H1 A1AC to 6%? How much time in your patient it took?
Ma'am,
4 weeks or?
A1C usually takes time. We maybe 2 months or 3 months it can take time. So in this case, for that particular patient, why I highlighted the CGMS part. So I think in this patient, the best part is that you put a CGMS, see time in range, quickly titrate your medication. After 2 to 3 weeks later, you again put a CGMS and see what's the time in range. So the quick assessment is a pre-meal and post-meal, and the better assessment will be the time in range for such patient, because A1C will not be a good marker.
Okay, so it's not a good marker to repeat
even in the CGMS system, because there is a things, because the trials are showing that even the patient is having A1C less than 6%, your pre-meal, post-meal goals are accomplished, your time in range is not good for such patients. So this technology.
Yes, A1C is important only the prenatal. If she comes to you, visits to you with a high BMI index, then the A1C, we should do the A1C also.
Yeah, A1C we do for a patient every 4 weeks. It's not that A1C is not handy. When we talk about if we want to improve the outcomes further, so it's basically you just going a step ahead. So MTP, there is no, I think, guidance to counsel patient for termination. We can't counsel patient for termination.
Suppose if
Right,
it is
we can
11, suppose if it is 11,
even it is 11%, even it
in
is
first
12%.
trimester, in first trimester.
Yeah. Even it's 11%, 12%, you can't say patient to go MTP.
Okay.
Because there is no guidance to dictate patient. Because there are some patients who have landed us with 12%, 13% A1C. We have explained. There is a high risk of congenital malformation. There could be a high risk of poor maternal and outcomes. But I don't remember any of the lady has undergone MTP. And all those ladies who have preferred to continue their pregnancies have delivered a healthy baby. So I think we are nowhere to dictate MTP. We can just explain that this could be the risk. And the choice should be theirs.
We can counsel the patient, tell about the percentage of congenital anomaly.
Yeah.
If it's less than 6.5%, then only 3%. But if it's more than 8.5%, then it could be more than 20%.
Yeah.
So that patient has to decide. So here comes the role of strict glycemic control before planning pregnancy, and preconception counseling is very, very essential, especially about the sugar control and hypertensive. Only 3 drugs we can give to them: nifedipine, methyl dopa, or
Labetalol or nifedipine.
and labetalol. Yes, all these only. Methyl dopa is not available. It's fine. So we can go labetalol and nifedipine. That's.
Interpretation information of HbA1c results?
That's why, ma'am, one should be clear. One is a pre-meal and post-meal. When you see a discordance, obviously you can.
I'm talking about HbA1c, sir. Suppose
Even
the patient is anemic.
one should be
7.
aware to what degree it can affect, right? If it is a mild to moderate anemia, it may not affect. But if it is a mild anemia, it may not affect. But if it is less than 8%, obviously it has some implications. Then the implication could be like 0.4%, 0.5%. So if you have a 8% versus 6%, you can still make some sense, right? But it is not like if it is 6.5 and 6%, then so you can make some sense of data if you know what degree of it can affect.
Thank you.
Thank you very much, Dr. Gupta.
Okay,
Very beautifully explained about the medical nutrition therapy, the calculation of the calories depending upon her BMI and depending upon her physical activity level. Beautifully explained. Thank you so much.
Thank you so much.
Sir, one question please. If
I
in this
think-
case, we would start metformin along with insulin
No.
on a higher BMI,
So for it's clear cut three things. If patient is having chronic hypertension and you suspect that patient going to preeclampsia,
sir, metformin.
yeah, I'm talking about metformin. If it is a chronic hypertension, you suspect that patient can go into preeclampsia, then usually ADA says that don't start metformin.
If he is not, if he feels he is not going into
Yeah, if it is no,
would it benefit?
yeah, then obviously we do. But try to restrict till 1 gram. Till 1000 milligram.
Yeah,
I'm very reluctant to go beyond 1000 milligram. Yeah.
Yeah.